Good morning, everybody, and welcome to the next in our series of Grand Rounds. Today's Grand Round is going to be given by Dr. Toral Gathani on the impact of the COVID-19 pandemic on breast cancer referrals and diagnoses in 2020 and 2021. And this is a population-wide study from England. Many of you will know Toral, but she's the Senior Clinical Research Fellow in Epidemiology, but also a consultant breast surgeon. She is based in the Cancer Epidemiology Unit, but is also an Oncoplastic breast surgeon and a Senior Research Fellow at Templeton College. And I'm also delighted to say that she's been awarded the very prestigious Hunterian Professorship from the Royal College of Surgeons of England, and that's news hot off the press early the new year. She's studied medicine at the University of St Andrews and then in London at Guy's and St Thomas's, graduating in 1999 with honours. She undertook a surgical training both in London and at the Nottingham Breast Institute. She is a member of the National Clinical Advisory Panel for Cancer Research UK and also the Academic and Research Committee for the UK Association of Breast Surgery. She was appointed Senior Research Fellow at Green Templeton in 2019. Toral, we're delighted to have you speak again, and I was just talking about the excellent stuff you talked to us about last summer. So over to you.
Thanks, Ashraf. That's very kind. So I'm just going to share my screen. So I'm going to talk about some work that I've been doing with colleagues to assess the impact of the pandemic on breast cancer, and particular co-investigators and collaborators that I would like to acknowledge, based here in NDPH and also Public Health England, Gillian Reeves, David Dodwell, Kieran Horgan, Olive Kierans, Sawan Khan and Sean Sweetland, and I'm speaking on behalf of us all this morning. So the first thing to do is just to give a little bit of background about the epidemiology of breast cancer. And the age is the most important risk factor for breast cancer. And we look at this graph here, and we can see that there's up to about the age of 50, there's an increasing incidence, and then it kind of takes off after that in postmenopausal women. And what's the importance of that relates to how we diagnose breast cancer. So essentially, there are two routes to diagnosis for breast cancer in this country. One focused on early detection, which happens through population-based screening, and currently asymptomatic individuals get 3 yearly mammograms aged between 50 and 70. And we had the AJAX trial running, which was randomizing women to see whether there was benefit of an extra round of screening in younger women aged 47 to 49 and in older women aged 71 to 73. And then the other route is the symptomatic route. So this is basically women, and this is to promote early diagnosis. And this is referral essentially from primary care to secondary care with women with breast symptoms. And currently GPs can refer patients in either as being urgent or routine. And in terms of practical pathways, these patients need to be assessed within 14 days of referral, regardless of the triaging by the GP of the level of urgency. And then there is about a smaller proportion who will come through different routes, which include emergency presentation, most commonly due to metastatic disease. We have high-risk surveillance programs for people with family histories. And increasingly, we're also seeing incidental findings through cross-sectional imaging. So a scenario there would be a patient comes in through accident and emergency, for example, has a CT scan for another reason, and a nodule is found within the breast, and then they'll be referred into the service. And then in practical terms, what does it mean in the terms of numbers that we're actually seeing? So this graph below is showing the proportion of breast cancer diagnosed via each route of the preceding 3 years. And we can see that roughly 40 to 50% come through this urgent referral pathway. About 40% come through as a result of screening. And then a very small proportion here, 5% of referrals, come from this routine pathway. And this is the actual number of cancers. So in the UK, there's about 50,000 breast cancers diagnosed each year. And, so you get about 22 to 23,500 through the urgent route, only about 2,000 to 3,000 through routine. And screening sits at around 17 to 18,000 cancers a year. And so when we then look at the, so I've already explained to you that the incidence of breast cancer is highly correlated with age, but because of these different routes to diagnosis, the proportion of cancer diagnosed at different ages is influenced by that. And what we see here is this is showing you the actual proportion of patients in the different age groups. And broadly, 20% of breast cancer is diagnosed in women under the age of 50. About 1/3 of breast cancer is in women over the age of 70, and about half of women are of screening age. And amongst these women, 60% of their breast cancers will be screen detected. And in the context of looking at COVID, given the association between COVID and age, it's kind of important to understand the patterns of referral and diagnosis for breast cancer itself. And then the other thing which I want to, the other aspect which I think is important to understand is the factors that influence survival. And so this little scheme at the top is the cancer control continuum, where we start with etiology and prevention and moving through. And those are the factors that will influence incidence. And then the factors which influence survival, which are early detection, early diagnosis, and access to treatment. And then we come to the effects of people living with cancer, issues around survivorship. And then we also have to have plans and service for people who are coming towards the end of life due to breast cancer death. And the graph below is showing what the gains have been in survival for breast cancer over the last 4 decades. And in the 1970s, the proportion of people who were living with 5-year survival for breast cancer was about 50%. And now it's kind of like in the high 80s, low 90s. And what has driven these gains has been basically improvements in these things. So through early detection, early diagnosis, and better access to treatment, we've seen a noticeable improvement in breast cancer outcomes. And of course, the concern would be with the pandemic is that these gains will be lost for various reasons. And then to come back to early diagnosis and the importance of that, and it's all because about stage and survival. So this is showing you what the relative survival is for breast cancer by stage. And stage 1 disease has almost 100% survival, and people who present with stage 4 disease, 1 in 4, only 26% 5-year survival. And in UK currently, about 85% of breast cancer is diagnosed at stage 2 or below, which is basically disease that's confined either to the breast, small cancers confined to the breast, or small cancers with a very low level of nodal involvement. And this is very, very treatable disease. And anything that will influence stage diagnosis will result in poor outcomes and survival. And then for those of you who may not be so familiar with how we treat breast cancer, just to remind you that the approach to the treatment of breast cancer is multimodal, comprising of both local and systemic therapies. With regard to local therapies, we have surgery and radiotherapy. And surgery is the mainstay of treatment for breast cancer. And it's either breast conserving surgery, which involves removing the cancer within the breast and a margin of tissue around it, or a mastectomy, which is the removal of the whole breast. And then radiotherapy will be delivered to the breast or the chest wall and regional lymph nodes as indicated. And then with regard to systemic treatment, we very broadly have 3 classes of drugs that we use: hormonal therapy, chemotherapy, and the biological therapies, which are drugs like Herceptin and which target, which are immunotherapies. And the choice of the systemic therapy is influenced by a combination of looking at the stage of the cancer, the grade, and the receptor profile, and the tumour characteristics that are clinically relevant to us at the stage, which is a combination of size and nodal status, the grade of the cancer broadly, whether it's high grade or low grade, and whether it's ER positive or negative, Herceptin receptor positive or negative. In terms of treatment sequencing, usually for most patients, we will operate on a patient first, and then they'll have some systemic treatment and or radiotherapy. But there are circumstances in which we may wish to give primary systemic treatment, and for patients who are going to be offered systemic therapy, there may be reasons for giving it up front. Okay, so that's just to give you an overview of how we would approach the treatment of breast cancer, and in the context of COVID, to understand the changes that we made. And then the final background that I want to give is this, and which is the symptomatic breast service. And for those of you who work in breast cancer will know that the service is currently in crisis nationally, but it has been for quite a long time. And these graphs essentially explain why. So these are the number of referrals over the last 10 years. And this data is publicly available through the National Cancer Intelligence Network. And this is the actual number of referrals. So these are hello. These are the number of referrals that come through the urgent pathway, and these are ones that are routinely referred. And what we can see is that over a decade, the absolute number of referrals for urgent referrals has gone from around 200,000 in 2009-10 to in 2019-20, almost 450,000 women were referred, and the routine referrals has sat at around 200,000 over the same time period. But what is noticeable is this corresponding graph, which shows the conversion of these referrals that end up in a cancer diagnosis. So in 2009-10, about 10% of referrals ended up in a cancer diagnosis, and this is almost halved to sitting at around 5.7% now. And for the routine referrals, less than 2% will convert to a cancer diagnosis. And it's a huge amount of work. The symptomatic breast service involves radiology, physical assessment, and also a tissue diagnosis if needed, the so-called triple assessment, which is incredibly labour intensive. And units all over the country are struggling with this kind of marked increase in referrals. And since the pandemic, this number has gone up even more, which I'm going to show you shortly. So just to remind everyone, in case you've forgotten, there has been a pandemic over the last couple of years. And what happened? So in March the 17th, 2020, a letter came down to the trusts, which was entitled Important and Urgent Next Steps on the NHS Response to COVID-19. And essentially this instructed the trust to free up inpatient and critical care capacity. And this was in anticipation of a wave of COVID patients coming. And it was cascaded down through the hospitals, and we looked at our planned activity and cancelled and postponed it as needed. And then on March 23rd, the national lockdown began. In terms of breast cancer services, routine screening invitations were paused. And there was also further instructions that were cascaded down from our specialty organisations talking about treatment sequencing. So you'll remember that I talked earlier about the fact that that surgery tends to be the first treatment offered, but there was a clear advice given about circumstances in which patients could be put on hormonal therapy, for example, and their surgery delayed. And also looking at the prioritisation of our cancer cases, and again, looking at those tumour characteristics and assigning priority codes to patients where the cancers were considered prognostically adverse or prognostically favourable, and then coming in with a fairly robust nationally agreed triage system for how to approach them. And then there were 2 further lockdowns with stay-at-home advice, but with the caveat at that point, stay at home, but unless you need to go to the hospital. And that was in November to December, in the whole of November effectively, and then starting again at the beginning of January for 3 months. And understandably, significant concerns have been raised as to what the long-term and the short-term impacts of these measures will be on other diseases, including cancer services and cancer outcomes. And initially, there were papers that were published. So these 2 papers were published in the same issue of the Lancet Oncology in August 2020. And they were modelling studies, which were based on quite a lot of assumptions and historical data, which painted a very bleak picture of what the effects of suspension in services were going to be. Certainly, the cancer charities were very concerned, and there was a lot of publicity about that, about unnecessary, about increased mortality from cancer due to pausing of routine services. And this then fed into the media. And these are examples of headlines from the Daily Mail and the Guardian, which understandably created a lot of anxiety. And around that time, so last summer, I did start to wonder whether, for breast cancer, whether the kind of forecasts were valid. And actually, I kind of wondered, how can we actually look at the impact of the measures introduced to control the COVID-19 pandemic, and where was the real-time data that we'd be able to look at it with. So the potential data sources that we could have used, there are essentially four. So there would be the gold standard would be considered to be the National Cancer Registration and Analysis data set, which is the data that comes from the cancer registries, and this would be considered the gold standard. However, there's a time lag, so the data for 2020 will not really be available, won't be available till the end of this year. So that's gold standard data, but there is a time delay, and it also requires formal application to get it. And then there was another data set that's been developed during the pandemic, which is in the public domain, and people can look at that, and that's the Rapid Registration Cancer data set. But for breast cancer, it's got limitations in that it doesn't include DO5 disease, which is breast cancer that's in situ, which is about 20% of our cancer burden. And there's also a lack of information about hormonal therapy, so it limits what can be looked at there. And then there are two data sets, and again, it requires application. If you want to get more granular, so aggregate data is available in the public domain, but if you want patient level data, you have to apply for it. And then there are data available in the public domain which provide very useful real-time information. So these are the cancer waiting time data sets, and newly developed during the pandemic, the COVID-19 cancer equity packs. And the cancer waiting time data publishes on a monthly basis the number of referrals, the number of first treatments for each cancer site, and you can get a very real-time picture of the amount of activity that's going on. There's no patient level data available, and it's entirely aggregate, but it is useful. And the COVID-19 cancer equity packs now break down some of that data by age, ethnicity, and deprivation. So looking at, so what we decided to do was to look at this using these two data sources. So data that was relevant to breast cancer, we extracted from January 2019 to June 2021 from these two national data sources to look at both the referral numbers and the first treatment numbers. The first treatment data can be used as a proxy for a diagnosis of breast cancer because patients have to be treated within 31 days of diagnosis. So what you can look at, if you look at the number of first treatment activity, you can make an assumption that that reflects the number of diagnoses that are going on. We then estimated the ratio of the monthly counts for the routine and urgent referrals and also for the first treatments in 2020 and 21, and we calculated against that to the corresponding month in 2019, and using this with the underlying assumption that 2019 represented a normal year of activity. And where data were available, we further examined these ratios by age, ethnicity, and deprivation. And these data are available, anyone can look at them, and these are the links to them. And these results have been written up and they're published in the British Journal of Cancer and the British Journal of Surgery. So looking at referral activity, first on, so the figure on the left is the urgent referral activity, commonly known as the 2-week waits. And on the right, we're looking at routine referral activity, which are patients with symptoms where the GP has a low suspicion of a cancer diagnosis, but nonetheless, all of these patients need to be seen within 2 weeks of referral. And along the bottom, you've got the month of interest, and this is showing you the ratio of counts. So this is 100%. This is compared to the corresponding month in 2019. So in January 2020, the same number of patients were referred urgently as they were in January 2019. And what we see here is this very dramatic effect of the pandemic, and this is April 2020, where referral rates fell to 40% compared to April 2019, but equally with a very rapid recovery. And by August 2020, the volume of referrals for urgent assessment were the same, and then they've exceeded it and stayed elevated over the corresponding, over the time since then. And most importantly, we also notice that they withstood the pressures of the second and third national lockdowns. And currently, we're seeing referral rates that are almost 20% higher than they were in 2019. Routine referral activity had the similar pattern of a massive drop and then a recovery, but it's always been lower than what it was in 2019. And what we don't know is how many of these are, these referrals that previously would have been referred as routine are now being referred as urgent. But overall, there's about a 13% increase in the number of referrals that we're seeing. And then looking at this further by age, ethnicity, and deprivation, what we can see is similar patterns. So age, we've presented the data in women who are under 50, so therefore present through symptomatic routes, women who are over 70, again presenting through a symptomatic route, and then these women in the middle who are 50 to 69, who could present either through screening or be referred. And what we see is very, very similar patterns of the decline and the recovery. Looking again at ethnicity, and it's very crude ethnicity groupings that are available in this data, just white, Asian, and black. And again, we see similar patterns of the decline and the recovery. There may be some suggestion here that Asians are being referred at slightly lower numbers compared to whites and blacks, but I would caveat this data quite heavily to say that it's very early data, and I think we do need to wait for gold standard groupings with regard to ethnicity to see whether there really has been any effect. And one of the reasons why we're interested in this is because we know that there are associations between ethnicity and COVID, and so one would wonder whether that leads to a greater effect of in terms of the health-seeking behaviour in these groups has a bigger impact. And reassuringly, looking at referrals by deprivation, we also see that, and these are just put into two groups, of least deprived and most deprived, and again we see a similar pattern. So what do we conclude? So we see that by August 2020, the activity had surpassed pre-pandemic levels and it remains elevated, and the pace of recovery is broadly similar by age, ethnicity, and deprivation. And then the other thing that we can look at is performance. And what do I mean by performance? So performance is the ability of the service to provide timely assessment for patients, and the standard that is required, mandated by the cancer waiting times, the standards that govern the cancer waiting times in this country, that 93% of patients should be assessed within 2 weeks of their GP referral. And what you're looking at here are the years in different colours. So pink is 2019, the blue is 2020, and the grey is 2021. And this is urgent referral performance, and this is routine referral performance. And what we see is that the service has been struggling. So in 2019, it was struggling at the beginning of the year, and then there was some recovery towards the end of the year. And what we observe in 2020, that performance got better as the volume of referrals went down, but we see that there's gradual decline in performance as the volume of referrals has gone up, suggesting that the system is at capacity, and we see a similar pattern for the routine referral. Now, this is a measure of time to assessment, and what we now have in cancer services is a new target, which is the 28-day standard, which is a measure of time to diagnosis rather than time to assessment. And the 28-day standard was due to be introduced in April 2020. It was delayed by 12 months because of the pandemic, and it started to be reported at a national level since April 2021. And 28 days is basically, the definition is that within 20 days, 8 days of the referral from the GP, a patient has to be told whether or not they have a cancer diagnosis. And in terms of clinical utility, it's far more useful, because that's what we're focused on, isn't it? It's early diagnosis. We want people to be told that they've got cancer as soon as we know that they've got cancer. And the standard for the 28 days is 85%. And we can see that actually, whilst the referral performance, the time to assessment is doing badly, we're actually doing pretty well on confirming the diagnosis. We need to do more work on trying to understand who these people are who are not being told that they've got a diagnosis, who haven't either been reassured or had a cancer diagnosis confirmed. And if it turns out that all of these people who are not meeting the 28-day standards are people with cancer, then that's a problem. But that data are not yet available, but it certainly needs to be looked at. So what are our key observations with regard to referral activity? Firstly, that the overall number of referrals largely recovered by August 2020, and that services had learnt how to work during a pandemic and withstood the pressures of the second and third lockdowns. More patients are now referred urgently than they were previously. The patterns of recovery are similar by age, ethnicity, and deprivation. Demand has outstripped capacity for timely assessments, and nationally, overall performance is poor for time to assessment, but the time to diagnosis is still pretty good. And it probably suggests that the impact on diagnostic delay is likely to be small, but we need to examine this further. So moving on now to first treatment activity. So this graph is, and you'll remember what I said before, that we're using first treatments as a proxy for a diagnosis of cancer, okay? And what we see here is that there was a spike in first treatment activity in March 2020. It then fell off, and then again it recovered, but the recovery for first treatments was slower and recovered by the end of the year, and then has been sustained throughout. And this surge of activity that we see in March 2020 was probably due to patients whose treatments were either being brought forward or because we were starting them on hormonal therapy for their breast cancer where appropriate, and kicking their surgery further down the road. And these are, and what you can do is you can look at the actual numbers and calculate the differences. So this is looking in 6-month intervals. So this is January and June 2019 and January and June 2020 and then 2021, and in July to December, and then again in January to June. And these are absolute numbers of people who are treated. So you can make the assumption that this is the number of diagnoses. And there was a 4,000 difference for January to June 2020 compared to 2019, almost a 5,000 difference for the second half of that year. But in 2021, in the first half of 2021, there were only 700 fewer diagnoses compared to the first 6 months of 2019, suggesting recovery. And then there are about 9,500 missing cancers since the start of the pandemic, and about 8,500 were in 2020. And we can attribute about 65% we can attribute to the pause in screening. And we know that screening was paused effectively for 3 months. We also know that normally about 1,500 breast cancers are diagnosed through screening each month. And then there was probably about 50% activity for another 3 months. And so if you do the maths on that, you can explain quite a lot. You can calculate those numbers. And then looking at the number of referrals, again, we know what the conversion rates are to a cancer diagnosis. And so if you look at the fall off in referrals, you can work out why those cancers are missing. So that's where we're at. So there's probably about 9,000 cancers that are unattributed, that are currently missing, but we're not quite sure where they are. And then looking at this data broken down by individual characteristics. So firstly, looking at it by age, and the hypothesis that I put forward that the missing cancers are largely due to a pause in screening is supported by these data, where you see here in this group of screening age, you see a lag in their recovery compared to women who would only present through a symptomatic route. And this is screening catch-up, I think, that's coming on here in women who are aged 50 to 70. But again, by the end of the year, by December 2020, they've all caught up. They've just done it a bit more slowly. Again, reassuringly, by ethnicity, we see similar patterns of decline and recovery, and by deprivation as well. So by December 2020, activity had reached pre-pandemic levels and has remained largely sustained. And the pace of recovery has been slowest in women of screening age, but we see similar patterns by ethnicity and deprivation. And the other point to make is that performance for treatment has remained better than assessment throughout. But in 2021, again, services are struggling, and the performance remains below the target. Only slightly, though. It's about 92. Performance is sitting at around 92, 93%, and the target is 96% of women to be treated within 30 days of diagnosis. So to conclude, to our knowledge, this is the first study that's examined using real-time data the effect of the pandemic on national breast cancer service activity and performance, both overall and broken down by certain patient characteristics. What have we shown? That there was a significant impact of the first wave of the pandemic and the national lockdown, but a lesser impact of the second and third lockdowns, despite the greater severity with respect to COVID-19. There is a crisis in diagnostic capacity which needs carefully considered solutions, and we need to create a very robust evidence base which will support any guidance for a change in referral practice. And we also need to do further analyses to understand what the reduction in numbers means in terms of things like stage of presentation, other tumour characteristics, and potentially whether there will be an impact on survival from breast cancer in future years due to the pandemic. And these data will become available over time. So I thank you for your attention, and I'm happy to take any questions.